happy, and my name is Amr Rifai, Senior Product Manager. In Saudi market especially, we are looking for adding value for healthcare professionals through continuous medical education activities and sharing up-to-date insights to serve the healthcare professionals community, which will have positive impact in your patient's quality of life. I will start with just 5 to 7 minutes presentation about Dar al-Dawa. The objective of the presentation to illustrate what we are, what is the source of our heritage.
Yes.
Yeah.
Okay. Dar al-Dawa, trusted quality. We'll start with our vision and mission. DAD is the abbreviation of Dar al-Dawa. DAD aims to become the foremost pharmaceutical partner for key stakeholders keen on improving health outcomes, cost of care, and the well-being of patients and their caregivers. Our mission to be a leading pharmaceutical company dedicated to serving patients, healthcare professionals, payers across the world. Our mission in Dar al-Dawa to make medication affordable and accessible with high quality of Dar al-Dawa for all patients in MENA region. Our values, which is the core of all our activities in all markets in MENA region: honesty, performance, emphasize, care, responsibility, entrepreneurship, leadership, and last but not least, innovation. Dar al-Dawa, established since 1975 and the headquarters in Amman, Jordan, we are serving healthcare professionals and the patient community since more than 4 decades. And this is the source of our heritage. We serving healthcare professional communities as well as patients for more than 4 decades. The dedicated Dar al-Dawa staff is over 900 staff in more than 30 countries in 3 continents. We are serving Middle East, Africa, and Europe. And our products cover a lot of main therapeutic areas in different MENA region countries, including antibiotic portfolio, respiratory tract portfolio, cardiovascular products, CNS and musculoskeletal products, GIT related products, genitourinary system and sex hormone products. This is briefly what is Dar al-Dawa, what is the cause of our existence, what is our values, and what is our huge portfolio in different countries in MENA region. Thank you. Now I will shift to the second part in our webinar today. Talk of Dr. Wael Abdelkafy, entitled Upper Respiratory Tract Infection Management, Case Scenarios and Guidelines Update. Briefly, Dr. Wael will add value for healthcare professionals through the up-to-date data and the clinical practice. Dr. Wael is consultant and head of Otolaryngology, Head and Neck Surgery Department, in Dr. Erfan and Bagedo General Hospital in Jeddah, Saudi Arabia. Dr. Wael is lecturer in Suez Canal University School of Medicine, Egypt, and has international training and experience in otolaryngology, head and neck surgery, fellowship USA, ear and skull-based surgery, fellowship in Switzerland. Also, Dr. Wael has a lot of publication in basic science research, airway reconstructive surgery, ear and skull-based surgery, in addition to more than 20 years of clinical practice expertise. Now I will let the mic to Dr. Wael to start his presentation.
Thank you very much for the introduction. Thank you so much for the introduction, and thank you so much, الدواء Pharmaceutical Company, for the invitation. It's really an honor to be among you here today, and thanks for all the attendance. Thank you so much. In choosing the title for this presentation, well, we thought we should take a break from all this COVID-19 overwhelming data every day. And let's go back a little bit for our regular practice, what we see every day in the clinic, what we see every day in our practice, in our hospitals, in our offices. Just to highlight the importance of the subject, upper respiratory tract infections are everyday work. I'm talking about ENT, internal medicine, pediatrics, general practitioners, even ER. So it's everyday work. And it's very important part of our practice. I will just start by the definition. I will talk about the symptomatology and the importance of how to differentiate between clinical pathological types, mainly is it viral or bacterial, and the dilemma of the diagnosis. Sometimes it's simple, sometimes it's a little bit complicated. And what are the management and the guidelines? And during the management, what are the important case scenarios that we should take care of, or pick those cases and how to deal with them, and the clinical case scenarios with the management. Upper respiratory tract infections can be defined to acute infection, whether in the nose, sinuses, pharynx, middle ear, larynx, epiglottis, and main airways like bronchus. These infections are usually clinically diagnosed in the clinic according to the infiltration or the most part affected. If you're having a patient with sneezing, rhinorrhea, that's probably rhinitis or sinusitis. When you're having throat pain, pharyngitis, mainly it's cough. But sometimes you can get a mix of those symptoms together. So we can classify them, as I said, to pharyngitis, tonsillitis, laryngitis, epiglottitis, whether the symptoms, it is hoarseness of voice, throat pain, sinus-related symptoms, ear pain, blockage, or chest-related symptoms. So that's the first presentation of the patient. You can get your patients, or you can see your patient in your clinic or in the ER complaining from one or more of these symptoms, either coughs or throat, runny nose, nasal congestion, ear pain or blockage, headache, fever, facial pressure, sneezing. You can see a patient with just malaise or myalgia, and you can get a mix of all of these. After that, after you see the patient from all these problems or complaints, just a mental process will start to work, just to think about, is it viral or bacterial? And that's a very important question. The patient's coming with sore throat, you know it's a pharyngitis, but is it viral or bacterial? So sometimes it's very simple. You can get runny nose, watery, without a lot of fever, and the diagnosis of common cold is really simple. But sometimes it's not that simple, as I will explain later. So the classical features of rhinovirus infection in the absence of signs of bacterial infection or serious respiratory illness is just very sufficient to make the diagnosis of common cold. But if you have those symptoms of common cold with high fever, you might think it's just a common cold, it's an influenza. And you might need to test for influenza A and B. Influenza A, we need to know whether it's an H1N1 or other strains of the influenza A virus. So the symptoms can dictate whether just to treat symptomatically or you ask for investigation to reach a proper diagnosis. Because if it is influenza, you might need to add Tamiflu or antiviral agent. If it's just common cold, you don't need to do so, and so on. Patient with pharyngitis or throat pain, is it just bacterial pharyngitis or it's viral? Maybe a rapid strep swab to rule out the diagnosis and to make the proper diagnosis so we don't abuse our antibiotics that is present in our hands these days. Sometimes patient with chronic or recurrent throat pain is only complaining from acid reflux. It's not even viral or bacterial. Sometimes the typical picture of the follicular tonsillitis, it's not bacterial, it's just an Epstein-Barr virus and infectious mononucleosis, which gives a picture very typical to acute follicular tonsillitis, but blood test may help in the differentiation. So another dilemma, or part of our dilemma in the diagnosis, whether it's viral or bacterial, it's not just viral or bacterial. Sometimes you can get viral diseases and secondary bacterial infection. So you can start with viral infection and you can end up after a few days with secondary bacterial infection. And this is a well-known entity. So common complications for respiratory viral diseases, just to end up with secondary bacterial infection. And co-infection or secondary infection is a bacterial infection that occurs during or after an infection from another pathogen. Commonly, the start is just a virus. Streptococcus pneumonia is the most common bacteria found in viral secondary bacterial infections. And when you get the secondary bacterial infection, the course of the disease is completely different. And you can end up with totally different scenarios. So Streptococcus pneumonia, Haemophilus influenza, and Staph aureus are the most commonly reported bacteria associated with influenza pandemics. And this is, many studies have reported this. So that influenza infection, it's been proven that it facilitates the acquisition, colonization, and development of disease from Streptococcus pneumonia in people of all ages. So just as a confirmation that you can start with viral and end up with secondary bacterial infection. And it's well-known scenarios here. Some examples that will explain this idea. A congested eardrum or eardrum pain that started with a viral infection from day one, this is probably a viral otitis media. But if you can get a congested or ear pain or congested eardrum after the viral infection with few days, that's probably a secondary bacterial infection. Runny nose at the beginning, that's probably viral. Of course, according to the examination that you will see in the clinic. But runny nose that persisted beyond 10 to 14 days, that's probably secondary bacterial infection. This patient might start with a cough or fever, and after a few days, and the initial diagnosis is a viral infection, but after a few days, he can get the discharge is different, the purulent discharge is different, and he's just acquiring a secondary bacterial infection. So it's very important to think about whether we started with bacterial infection or viral infection, we can get secondary bacterial infection. And keep this in mind when you get worsening of the symptoms or change of the disease course. Let's move to another section, which is the common viral infections that we face every day, the common cold, influenza, the Epstein-Barr virus. We have many others, but those are the very common that we see every day. The common cold, or sometimes we call it nasopharyngitis. It's caused by rhinovirus, adenovirus, parainfluenza, respiratory syncytial virus, and enterovirus. Usually the replication starts in the nasopharynx. So the patient comes complaining of pain behind the nose or in the throat upwards. And that's nasopharyngitis. That's viral infection, usually mild to moderate symptoms. All what you need is just symptomatic treatment. There's no vaccines available for those viruses. So but again, if after a few days, the patient came back with the worsening of symptoms, change of the clinical picture, again, think about secondary bacterial infection. The influenza, which is a big issue here in our practice, even in the past few years. We know that there are 4 types of influenza viruses, A, B, C, and D, but we're concerned only about the A and B. And A in particular is divided into different subtypes based on the combination of 2 proteins in the viral surface, hemagglutinin, which is the H, and neuraminidase, the N. That's why we have an H and N. And there are 18 different types of H protein and 11 different types of N subtypes, N protein subtypes. So for example, the swine flu, H1N1. The avian flu is H5N1. The novel swine flu is H3N1. So that's why we have the difference in the numbers according to the difference in the protein H and protein N on the surface of the influenza A. So when you suspect influenza virus, you might add here antiviral agent, but it's important to take a nasal swab and to diagnose that there is an influenza A and B, and you can add the Tamiflu, but you cannot add Tamiflu without having the diagnosis of influenza infection. And for influenza, we have a seasonal vaccine available. And the infection with either influenza A and B can cause symptoms that last around 1 week. Some may have cough or fatigue even after 2 weeks. Some influenza A subtypes can cause more severe diseases than others. So like influenza A H3N2 virus have been associated with more hospitalizations and death in children and elderly, more than the others. That's the novel swine flu that came a few years ago. And regarding the vaccination, just to highlight, we have the quadrivalent vaccine and the trivalent vaccine. The quadrivalent vaccine, that's vaccination against an influenza A H1N1 and H3N2 and 2 influenza B viruses. And the trivalent, it's a flu vaccine that protects against only 3 types. Influenza A, H1N1, and H3N2, and only 1 influenza B virus. So it's very important to know which one of the vaccines are available in your hospital and what are the strains available in the country, in the season. A very important example of the viral infection that we see quite often, and it's usually overlooked in our practice, which is the Epstein-Barr virus and infectious mononucleosis. And the importance of this virus, that the clinical picture is very, very similar to bacterial infection. So that's the tonsils. That's during a throat examination. Those are the tonsils coated with whitish exudate here as well. When you look at this patient from the first look, it looks very typical to acute follicular tonsillitis, and you start empirical antibiotics. But as a matter of fact, this patient has infectious mononucleosis. That's a viral infection. Other signs that can help with the diagnosis: severely tender lymph nodes. You can get enlarged spleen, but in ENT practice, we don't examine the spleen with our outpatient clinics. And even tender lymph nodes are very common in just bacterial tonsillitis. So when you suspect, usually those patients are suspected with failure of antibiotic treatment. This patient usually comes to your practice with sore throat, worsening of symptoms, and he's been taking 1 or 2 antibiotics without any response. So the practice here, we should test for the IgM antibody in the blood for Epstein-Barr virus, and not just change the antibiotic for another one. And when you suspect Epstein-Barr virus infection or infectious mononucleosis, we shouldn't give amoxicillin clavulanic acid, because there is a high incidence of skin rash associated with, the amoxicillin clavulanic acid with Epstein-Barr virus. We can end up with this annoying skin rash to the patient. Just keep it in mind. It's diagnosed by IgM antibody to the virus, and treatment is mainly symptomatic. We shouldn't give antibiotics, and especially amoxicillin clavulanic, if suspected, because the high incidence of this annoying skin rash. So I will move to the next section of the presentation with the common bacterial infection that we face every day. First of all, the rhinosinusitis, otitis media, and then I will go through tonsillitis and pharyngitis. Regarding bacterial rhinosinusitis, I will talk here about the acute rhinosinusitis, because chronic rhinosinusitis is beyond the scope of this presentation. That's what we see in the clinic, either starting as a bacterial infection or complicating a viral infection. So it's defined as an inflammation or infection involving the nasal mucosa and at least one of the adjacent nasal sinuses. So you can get the infection in the nose, and usually you can get infection from maxillary sinus, ethmoid, frontal, and sometimes even sphenoid sinuses. So acute rhinosinusitis is persistent and worsening of upper respiratory symptoms. That's when we get it as a complication of a previously viral infection. By examination, we would like to see one of those clinical signs. That's an endoscopic pictures of the patients. That's middle turbinate, and you can find pus trickling from the middle meatus with congestion of the turbinates. Again, pus trickling from the middle meatus. Sometimes you cannot see the pus inside the nose or from the middle meatus, but you can see it trickling behind the soft palate. So it's a postnasal discharge. So that postnasal discharge, just with oral examination with a tongue depressor, you can see the purulent discharge coming on the back of the throat behind the soft palate. That's an enough sign by examination to make the diagnosis of acute bacterial rhinosinusitis when you find this purulent discharge. The most common pathogens or bacterial infection encountered here is Streptococcus pneumonia, H. influenza, Moraxella catarrhalis. Very few of Streptococcus species or anaerobes or Staph aureus. Usually it's the first three. In children, it's a little bit different than adults. So again, regarding the types of the bacteria and the susceptibility and we should have our own. I always insist on trying to have our own data in different countries because it's different between the countries. Those studies are made outside and we don't know as those bacterial populations with these percentages, are they the same in our country or in the Middle East or not? So that's a question we should raise every time. We should have our own data regarding the bacterial population and the bacterial resistance and antibiotic resistance as well. Okay. So that's a study in the American Academy of the Otolaryngology Head and Neck Surgery. They are just testing the different antibiotics in use with the common three species of Streptococcus pneumonia, H. influenza, and Moraxella catarrhalis. They are testing the amoxicillin clavulanic acid, amoxicillin, cefixime, cefodoxime, cefdinir, ceftriaxone, cefuroxime, and so on. And those are all effective antibiotics. So when we move to azithromycin or even erythromycin or clarithromycin, I mean the macrolides, they are not effective against H. influenza. Clindamycin is not effective against H. influenza or Moraxella catarrhalis, which are very common pathogens in bacterial sinusitis and in otitis media, as will come later. Doxycycline, very limited effect on H. influenza. Quinquinolones, good antibiotic, but again, in below 18, we cannot prescribe it below 18 years old, so it's of a limited use only in adults. So we are having those first seven antibiotics that we should choose from, because those are the pathogens that we are dealing with in acute rhinosinusitis. But again, this study, it's made and published outside. It's not made in our country. We don't know if we made this study in our country or in the Middle East, we can get the same results or not. So that's very important. And that's the recommendations regarding the sinus infection, acute bacterial rhinosinusitis. If we're having mild or moderate symptoms, the treatment options: amoxicillin clavulanic acid, amoxicillin, cefodoxime, cefuroxime, cefdinir. And the doses may be different when we are having a moderate. So amoxicillin clavulanic acid, you can reach up to 90 milligrams per kg. In adults, you can reach up to 4 grams per day. So another issue I would like to highlight when dealing with acute bacterial rhinosinusitis, always look for those cases. So when you get a patient with acute bacterial rhinosinusitis, and you can have a puffy eyelids like this one, or swelling in the frontal bone like this. Now, this is not the regular or the conventional acute sinusitis that we're dealing in our outpatient. Those are rare cases, but it's worth mentioning of those cases because those are complicated otitis media. When you're having sinusitis ended with this situation, you can have this from the first day or a few days later, but this is either preceptal cellulitis, orbital cellulitis. So those are severe complications. This is a puffy tumor as accumulation of pus in the frontal sinus and destruction of the anterior table of the frontal sinus, or anterior and posterior table together. So when you find things like that, that's an emergency. So they need to be referred to an ENT specialty for CT scan. Those are candidates for parenteral antibiotics. And within 1 or 2 days, if you don't get any response, we should move to surgical management. So those are not cases that we can manage in the outpatient clinic with comfort. Those should be referred immediately as an emergency. Regarding the acute otitis media, which is a common complaint that we find every day in the clinic. And I will talk a little bit more in acute otitis media and the variants, just to have a broader view of what's going on. So the acute otitis media is an acute inflammation of the middle ear cleft. When we talk about middle ear cleft, we're talking about the middle ear, which is behind the eardrum. We're talking about the eustachian tube. We're talking about the mastoid air cells. So that's the middle ear cleft. It's not just the middle ear. Sometimes it's complicating a viral upper respiratory tract infection. It's important points regarding the risk factors and the predisposition. Commonly in your practice, you can get the parents asking you about what's the relation between breast or bottle feeding with ear infection. That's a very common question. So how is the feeding with bottle or breastfeeding can cause otitis media? Well, actually, it's not the breastfeeding or the bottle. Well, breastfeeding is protective against any infection. But the problem is not in the feeding. It's in the feeding technique and putting the child supine immediately after breast or bottle feeding. Usually the child or the infant, he swallows air with suckling of milk. So this air swallowed, when you put the child or the infant supine immediately, you can get a lot of regurgitation of milk in the throat, in the pharynx, up to the nasopharynx. So that's the faulty technique that happens after feeding that can predispose to acute otitis media. So colonization of the milk in the nasopharynx can cause colonization of bacteria and predisposition to acute otitis media. So it's very important to get out this swallowed air after feeding before putting the child or the infant supine. Another very important factor here is the daycare. Once your child goes to daycare, he can get a lot of viral infections, and those viral infections will be complicated by secondary otitis media. So daycare is one of the main factors that can cause acute otitis media. Children with cleft palate or sometimes submucous cleft that is only apparent by examination of the soft palate. Here it's the diagram showing the difference between the eustachian tube in child and in the adult. In the child, the eustachian tube is more broad, wide, more horizontal. So any infection here can reach the middle ear easily through the eustachian tube right here. So that's why it's very common in children when you get viral upper respiratory tract infection to get propagation of the virus and causing bacterial infection or secondary bacterial infection in the middle ear because it's narrow, short, more horizontal. In the adult with development is different. So the angle is different. So to get a viral infection complicated by bacterial infection in the middle ear, it's not that much, it's not that prevalent in adults. So that's the typical look of what the middle ear looks like in acute otitis media. That's the eardrum, congested, bulging, red. And inflammation of the middle ear is really painful, whether in adults or children. Again, regarding the offending organism, we are talking about Streptococcus pneumonia, Haemophilus influenza, Moraxella catarrhalis as the main three pathogens. Sometimes Streptococcus, sometimes Staph, and we have here the high incidence of viral otitis media. So when you get a middle ear infection or ear pain or blockage, in the first day or in the second day of a viral infection, that's probably virus, because we don't have enough tools in the outpatient clinic to take a middle ear, aspirate and test for virus or bacteria. That's not practical. So that's usually viral infection. But if you can get middle ear pain and you examine the ear and you find this classical otitis media, third, fourth day, or after the viral infection subsides, then probably you're talking about a secondary bacterial infection. We're dealing mainly with those three pathogens like bacterial rhinosinusitis. And that's as an example of the antibiotic guidelines from the American Academy of Pediatrics. Again, we're having the choices here. The first line is amoxicillin or amoxicillin clavulanic acid. And we can see here the high dose that we should take. It's from 80 to 90 milligrams per kg. Cefdinir, cefuroxime, cefpodoxime, ceftriaxone, and so on. Again, when dealing with acute otitis media, there are very important points or clinical scenarios that we should take care from in our practice. When you get a child with acute otitis media and you can find protrusion of the ear like that, well, that's a complicated acute otitis media with acute mastoiditis. And the CT of this child will show destruction of the bony septa in the mastoid air cells, and even erosion of the bone of the outer cortex and trickling of pus here. So this case is not for just medical treatment as usual otitis media. It needs parenteral antibiotics, and if not resolved within 1 or 2 days, we can need external incision or sometimes incision of the eardrum just to relieve the tension. Another case scenario which is very important, yani alhamdulillah, it's not a common presentation, but if you have a child with acute otitis media followed by facial asymmetry, so this child can close this eye, move, you can feel this nasolabial fold. On the other side, the eye is open and the nasolabial fold is flat. So that's a facial paralysis complicating acute otitis media. That's very important. We saw it usually in our practice 3 to 4 times a year, but it necessitates a very different practice guidelines. This child needs antibiotic, needs steroids, and sometimes you usually need incision and drainage of the eardrum to relieve the pressure. The reason for having this complication, it's due to that in some patients or some children, there is a natural dehiscence of the facial nerve. We know that the facial nerve has a course inside the middle ear, but this facial nerve, it's going through a bony canal. Sometimes we can get a dehiscence, natural dehiscence. Part of this facial nerve canal is not covered by bone. So infection in the middle ear in a child with dehiscent facial nerve can cause facial nerve paralysis. So it's very important to give steroids, very important parenteral antibiotics, and to relieve the pressure on the middle ear and on the facial nerve by myringotomy. Myringotomy can be also used in acute otitis media not resolved by antibiotics, and there is severe pain. You can just relieve the pressure. Don't wait for the perforation to happen, but just incision drainage will resolve a lot of issues here. One of the variants of acute otitis media, it is called acute bullous myringitis. That's usually in the course of a viral infection. It's very painful. The child comes to your clinic with severe ear pain. When you look at the eardrum, you will find this bulla right here. So, you know, when you have a burn and you will have a bulla in the skin after this burn, it's the same, but in the middle ear. So this bully formation, it's very painful. But that's a viral infection. That's not a bacterial infection. But you might think about adding steroids to the symptomatic treatment. Again, an important entity when we're dealing with acute otitis media or middle ear problems, sometimes the infection is not resolved completely, and there is a subacute inflammatory process in the middle ear, not completely resolved by antibiotics that you give first. Even when acute otitis media has been adequately treated, sometimes you can get retention of serous fluid or effusion in the middle ear. So that's why when we're treating acute otitis media, it's not enough to just monitor the pain. If the child, there's no pain, so we're successful. You need to examine the ear again and make sure there is no fluid retained in the middle ear after the infection subsides. So for example, I'll just highlight the different types when we're thinking about middle ear effusion. So that's a normal, that's a normal tympanic membrane. You can find it's translucent with a luster, and that's the handle of Malleus right there. So that's normal. When we're talking about middle ear effusion, that's a resolving middle ear effusion. You can see here that we have air bubbles behind the middle ear, behind the eardrum. Those air bubbles, it means that there is a fluid behind the middle ear, and sometimes the eustachian tube opens and brings some air inside, and there are bubbles here. So that's a typical sign for middle ear effusion. If this stage is neglected, you can end up with this one. So you can see here that the eardrum is retracted inwards, and it's not a serous fluid like here, it's a thick fluid. Sometimes it's called glue ear because it's really like a glue. In this variant here, the fluid behind the middle ear is not serous or glue, it's a mucoid discharge. And this mucoid discharge usually associated with low virulence bacteria inside. So when we encounter one of these variants of middle ear effusion, you need to give antibiotics, you need to give steroids to try, and you need to monitor the child. If this, again, those three stages were neglected, you may end up in the last stage. This is called atelectasis or atelectatic otitis media. The eardrum is totally atelectatic and adjacent to the bones medial to the eardrum. And this is almost the final stage, and it's very difficult to treat and very difficult to bring the hearing back to normal. So it's very important to detect the child or your patient in one of those stages. So I will talk here about the middle ear barotrauma, and that's a common complaint that we find in our practice. Well, usually patients who are flying or diving, well, there's no flying nowadays, but hopefully when the flights are back to normal, usually passengers getting into airplanes with just flu, viral infection. During the descent or the landing of the airplane, they can feel severe pain because simply they cannot equalize the air pressure because this viral infection is obstructing the eustachian tubes. The eustachian tube, the ventilation tubes that equalizes the pressure behind the eardrum, it's blocked by viral infection. So during landing, the outside air pressure is increasing and he cannot equalize the pressure. So this negative pressure inside the middle ear can cause a lot of pain, and it's a serious complaint. Sometimes passengers just from the airport immediately to the hospital. It happens frequently. By examination, you can find effusion in the middle ear and sometimes traces of blood. So this pressure can cause bloody discharge in the middle ear. Again, that's not a bacterial infection. You can find the congestion, the redness. This is a barotrauma. Sometimes it happens with diving. During the descent of the diver, he should equalize the pressure continuously. If he fails to do so, he can get the same problem with middle ear barotrauma. But sometimes it can be misdiagnosed as a bacterial infection, which is not. Whether the barotrauma or the middle ear effusion, if failed medical treatment, we can shift to myringotomy and grommet. The normal ventilation tubes are not working, so sometimes we use an artificial tube inside the drum just to ventilate the middle ear till the middle ear mucosa comes to normal. And within 6 to 12 months, the eardrum heals behind the tube and just expel it outside. I will move to tonsillitis and adenoiditis here, which is again one of the fairly common complaints that we see every day. It's an acute inflammation of the tonsils and adenoids, can be due to a variety of organisms. Streptococcus pyogenes, group A beta hemolytic streptococcus, is considered the most important treatable pathogen responsible for the acute tonsillitis. But we have a problem when we're dealing with tonsillitis. The surface culture is usually different than the core bacteria present in the core of the tonsils. This has been studied recently after we remove the tonsils in cases with tonsillectomy. So just open the tonsil and we get cultures from inside, from the core of the tonsil. And in many occasions, we found these organism on the surface of the tonsil, it's different from the organism inside or in the core of the tonsils, which make the clinical judgment is really difficult to choose the antibiotic sometimes. In acute tonsillitis, the clinical finding of exudate in the tonsil often suggests a streptococcal infection, like we see here. So that's exudate on top of the tonsil with throat pain, and sometimes with adenoiditis, you can find postnasal purulent discharge coming from the back of the nasopharynx right here. However, an exuberant growth of exudate is more likely from Epstein-Barr virus, like we talked earlier. So this case, it looks similar, but this is a viral infection. This is an Epstein-Barr. This is an infectious mononucleosis. So when you suspect it, just go for the IgM antibody testing and avoid amoxicillin clavulanic acid. And try to wait for the results before giving antibiotics, because this is a viral infection with just symptomatic treatment. And it's fairly common to get an AB virus infection. And this is usually overlooked in the practice. So we're dealing here with Streptococcus viridans, Staph aureus, and various Haemophilus species. I mean, those are the bacteria sometimes found in the core of the tonsils. And atypical bacteria even common. So the drug of choice when we're talking about acute tonsillitis, and that's again the reference for this is the American Academy of Otolaryngology, that agents that treat co-pathogens and resist beta-lactamases are superior to traditionally recommended penicillin because of this fact that core organism sometimes is different than the surface organism. So the primary choice of antibiotics, ceftriaxone, cefpodoxime, cefdinir, or with or without metronidazole according to your judgment. And we have an alternatives like clindamycin, amoxicillin clavulanic acid, but avoid if mononucleosis needs to be ruled out first. And first generation cephalosporins, with or without, again, metronidazole. But always when we're dealing with tonsillitis, think about that we can get surface organism and we can get core organism, and sometimes they are different. I would like to highlight here some case scenarios that we see again that can be misled with the diagnosis of tonsillitis. So here in this patient come to you without throat pain, just bad breath or bad breath coming from the mouth, and there's no pain. When you examine the patient, you find these whitish spots here in the tonsil. That's called tonsillolith. Those are inspissated materials. Sometimes it's called tonsillar stones in a large crypt inside the tonsil. So I've seen patients misdiagnose this as an acute follicular tonsillitis and they got antibiotics, which is not the situation. Those are just tonsillar stones. You can remove it in the clinic, but they will return again. Sometimes we can deal with these cases with laser cryptolysis, to flatten the crypts so they don't accumulate inspissated material like that. Sometimes we can deal with it with just tonsillectomy because of this problem of malodor breath from these inspissated material. Sometimes follicular tonsillitis propagates to peritonsillar abscess. You can find edema of the palate, the tonsil is pushed medially, and you need to get a test aspirate with a syringe to find if there is pus accumulation or not. If no pus accumulation, just proceed with your management with follicular tonsillitis. If there is, you need to take an incision and drainage of the peritonsillar abscess. So let's move to pharyngitis, which is just sore throat without any tonsillar affection. So it's a painful inflammation of the throat, the pharynx. Pharyngitis can involve some or all parts of the throat. I mean, pharyngitis is not only in the pharynx, but we can get involvement of the palate, the uvula, and the back of the tongue, the posterior part of the tongue. Some congestion of the tonsils can be found as well. So in the literature, you can find even the term tonsillopharyngitis, not just pharyngitis, because the infection can take the mucosa on the tonsils as well. So the Streptococcus pyogenes, the group A beta hemolytic Streptococcus, it's 15 to 30%. Group C, beta hemolytic Streptococcus, is 5%. But it's very important when dealing with pharyngitis cases that we're dealing with approximately 70% of viral infection. So throat pain without clinical or laboratory data of bacterial infection, we shouldn't give antibiotics because that's very common complaint, and we're abusing antibiotics if we are giving antibiotics to every case or most cases of pharyngitis. You will find a lot of resistance to the patients because according to the patient, when he has severe symptoms, that's when he needs antibiotics. So we should have some time to explain the situation that severity of the symptoms has nothing to do with the causative organism. Antibiotics for bacterial infection. Sometimes viral infection can cause severe pain, but antibiotics has no role in this situation. And sometimes you find it very difficult explaining this to the patient. So the antibiotic choices, we're talking here about first and second generation cephalosporins, amoxicillin, with or without clavulanic acid, erythromycin, clarithromycin, cefdinir, cefuroxime, and cefodoxime. Another variance in the diagnosis when your patient comes to you complaining from throat pain. Just check, sometimes there's no inflammation at all, it's just aphthous ulcer. So this is one big large aphthous ulcer, and those are multiple aphthous ulcers. Those ulcers will be very painful, and they can cause pain radiation to the ear. So the patient will complain about throat pain, and this pain is radiating to the ear. And don't rush to antibiotics when you find these ulcers. This is just an autoimmune response, or they are self-limiting ulcers. You can give painkillers, oral antiseptics, and sometimes steroids for rapid healing. But you don't need antibiotics for the ulcers, in spite of the severe pain. Sometimes it's fungal infection, moniliasis, like this whitish coloration of the tongue, the uvula, the palate. Sometimes the cause of the throat pain is rare viruses, but we come to see them every now and then, like the Coxsackie virus that can cause hand, foot, and mouth disease. You can find congestion, ulcers here in the throat, the palate, around the mouth, and in the feet. Sometimes it's just herpangina. Herpangina doesn't mean herpes, it's just herpangina caused by Coxsackie virus type A. We can find only ulcers in the throat. So after reviewing some viral or the most common types of viral and bacterial infections that we see regularly in our practice, it's very important to appreciate what does it mean, the guidelines of antibiotics, or how to use those guidelines. Guidelines present the basic principles of antibiotic use for acute upper respiratory tract infections. Those guidelines based on the bacterial population cultured from the sites of the infection and according to the bacterial resistance. And those studies are concerned with the country publishing those, still they are valid, and those are the basic principles to use. But we should use those guidelines with caution regarding the situation in our countries. So the physicians should use guidelines as a reference and the principles of practice while providing individualized care to the patients. Those guidelines are not a dictation for universal application to every patient. Another important issue is that no recommendations for the antimicrobial therapy can be absolute, and the clinician will modify them according to the special circumstances in his patient or community. We have a very common example here that the antibiotic resistance in the Middle East, we have the problem in our countries are much worse than the other countries because of the abuse of antibiotics. Usually patients can get antibiotic without prescription, and they are taking them for viral infection without going to the hospitals or doctors. So this abuse, we have a bigger problem of antibiotic resistance. And the antibiotic guidelines, they change according to the bacterial population, the antibiotic resistance in the community. So we should insist on knowing the latest results of the bacterial population cultured, what is the common, and the results of the antibiotic resistance. And we should encourage having those results every now and then. And there are many antibiotic guidelines from different countries. You can find American, Canadian, European, Australian, Korean, and we should have, and we should work together with our pharmaceutical companies to have our local antibiotic guidelines according to the previously mentioned facts of antibiotics, resistance, bacterial populations. So the choice of antibiotics should be based on knowing the possible offending organism, whether you do it clinically or you need an investigations for that, whether it's gram-positive, negative, aerobes or anaerobes. And you should always have an antibiotic alternatives. Some patients have allergic reactions. Some patients have GIT upset. So you should have alternatives to each prescription. And the antibiotic resistance, again, due to the abuse of antibiotics, resulted sometimes in changing the dosage. Long time ago, even more than 20 years ago, we used to prescribe amoxicillin as 50 milligrams per kg. Now you can reach 90 milligrams per kg just to get the desired effect. And thank you so much.
Thank you, Dr. Wael, for your valuable presentation. Informative presentation that touched the clinical practice. Please, if any healthcare professional has a question, you can write the question in Q&A part below on the screen, and Dr. Wael will answer the question at the end of webinar. Now, the third part of our webinar today, coping with دار الدواء, mission to make medication affordable and accessible to all patients in the MENA region. With دار الدواء trusted quality, we are honored to announce the launch of our new product, Cefdinir, in Saudi market. Now, I will let the mic to Dr. Firas Khreishi, marketing MENA marketing manager in دار الدواء, with leading players in the MENA region, to provide us with more information and data about Cefdinir and his talk entitled Cefdinir, the trusted power with compliance.
Thank you. Bismillahirrahmanirrahim. Assalamu alaikum jami'an. Thank you, Dr. Wael. Thank you all the audience for making this successful event. Thank you very much for the attendance, and many thanks for my colleagues from دار الدواء. I'm going briefly now just to present Cefdinir. As I'm already said, that is the new Cefdinir in Saudi Arabian market, and I'm not going to have some education about Cefdinir, but actually I just to announce the introduction of Cefdinir to Saudi market. So Cefdinir is Cefdinir third generation or advanced third generation cephalosporin, which has a power with compliance, the main issue in Cefdinir. Actually, Cefdinir, as I have mentioned, it has a bulky group that protects it chemically from beta-lactamase producing bacteria, as well as it is covering gram-positive bacteria. So the main pathogens that Dr. Wael has already highlighted are mainly gram-positive pathogens and negatives and anaerobes, which are the main causative agents in community-acquired infections, especially respiratory tract infections. So Zevanir, Sevdenir covers them all. So Dr. Wael mentioned, and from all your experience, you know and witnessed that the most gram-positive pathogens that are covered by Zevanir are Strep biogenes and A. galacti, as well as Strep pneumoniae as the most causative agent in some infections like acute otitis media, as well as Staph aureus and epidermidis. In the gram-negative, Zevanir covers Haemophilus influenzae and Haemophilus parainfluenzae and Moraxella catarrhalis. All, of course, as mentioned earlier, are the main pathogens in upper respiratory tract infections. And of course, it has an effect, positive or a very good effect on Escherichia coli, Klebsiella, and other gram-negative pathogens, and some anaerobes as well, although and despite the fact that they are uncommon in the most of the upper respiratory tract infections. The indications and risk indications are the most community-acquired infections in the respiratory tract infections, like acute otitis media, pharyngitis, tonsillitis, as well as acute bacterial sinusitis, and AACB, the smoking bronchitis, as well as other skin and skin tissue infections, especially after surgeries, because it resembles the most oral cephalosporin that resembles ceftriaxone, the mostly used injection or injectable cephalosporin in the market. I will go briefly on some clinical trials for Zevanir or Sevdenir in specific, comparing it with amoxiclav. As Dr. Wael has already mentioned, amoxiclav is the first-line treatment for most of the respiratory tract infections, but Dr. Wael has mentioned as well that the guidelines are made maybe in the US, in Europe, even in Asia, but actually in our countries, we don't have, let's say, strong evidence guidelines, so we cannot follow by the book. Actually, your experience mentioned that maybe amoxiclav or Sevdenir, like Zevanir, may be the first-line choice in acute bacterial rhinosinusitis. So in this study, two randomized investigator blind multicenter trials in the United States and Europe, 1,220 enrolled in US and 569 enrolled in Europe, to evaluate safety and efficacy for oral Sevdenir versus amoxiclav for the treatment of community-acquired sinusitis. And the study again showed that Sevdenir once or twice are equivalent to 500 milligram amoxiclav for 3 times daily, not once or twice. So we can see here that the efficacy are the same, but we have seen that compliance that I mentioned already at the beginning of my talk, that we are not here creating guidelines or recommending some choices for you, because you are the expert in this area, but Zevanir has less side effects, especially diarrhea, compared to amoxiclav, the first line, as mentioned earlier. As well, we have a study here for tonsillopharyngitis, for GABHS, group A beta hemorrhagic streptococci, which is the most causative agent for tonsillopharyngitis. As you know all, and Dr. Wael mentioned, that this bacteria is not beta-lactamase producing significantly. So the first line is penicillin, but the recommendations again supporting the use of cephalosporins or other alternatives to the mentioned penicillin V, because we have two things. We have mixed infections and we have the effect on tonsillar flora. So in this study, It was made on 40 children, comparing either penicillin to sevdenir because GABHS is susceptible for both. And after the treatment, we have the penicillin group that we see in this case that the growth or the presence of GABHS or beta hemolytic streptococci is 55% after treatment group, and it's 15% only for sevdenir group. So we are trying that the harmful bacteria that you can see clearly that it is as GABHS, it's higher than in the penicillin group. As beta-lactamase positive bacteria, after treatment as well, it was 85% for penicillin group, while 15% for sevdenir, like in zevanir. So we are protecting the patients as well by using zevanir from the regrowth or relapse of the infection by harmful bacteria. Finally, for otitis media, we are comparing sevdenir with high-dose amoxicillin, as Dr. Wael has already mentioned, that the recommended dose for AOM in pediatrics, it is an 80 to 90 milligram per kg per day. So we're talking about giving a child with 2 or 3 years old a gram or more from amoxicillin, which might cause diarrhea. So in this study, 318 children were diagnosed by AOM, received 10 days sevdenir, 40 milligram only per kilogram divided twice daily, versus high-dose amoxicillin. The result, the objective was to compare the efficacy and safety as well for those children. And the results were evident. As you can see that the efficacy for both trial arms are comparable in terms of cure rate by 82 to 85%, while the compliance, what do I mean by the compliance? It is here first, adherence to the drug first. It is the complete result for using antibiotic, because it's very, very important thing, as you know from your experience, that for children and even for adults, not to have diarrhea and to accept the taste of the suspension and to take it twice daily as easy as they can. So it is a compliant antibiotic that gives you the efficacy that you desire, and to eradicate the bacteria that you want to eradicate, which are normally present in community-acquired infections that you see in your clinic. Here we can see the better taste. It is significantly towards sevdenir, and diarrhea significantly higher in amoxicillin, and the withdrawal, as you see, it is a much higher, 8 persons versus 1 person only from the trial has withdrawn due to side effects or other reasons. So finally, for zevanir from sevdenir that you are familiar with, I just want to introduce zevanir as الدواء quality product for you, our partners, our physicians. It is which has a comparable efficacy to amoxicillin treatment for many indications in the upper respiratory tract infections, like acute bacterial rhinosinusitis, as well as acute otitis media, as well as tonsillopharyngitis and AECB. It recovers your patients from most of the community-acquired pathogens, and with compliance for the parents, compliance for the diseased patient, and it is affordable for your patients in the Saudi market. Zevanir now in Saudi Arabia comes in 2 forms, the capsule form and the suspension form. The capsule form comes in 50 Saudi riyal, while the suspension in 30 Saudi riyal, and very soon, inshallah, you will have zevanir with different volumes in the Saudi market. I thank you very much for your listening. Thank you very much for your interest and belief and partnership with الدواء, and we promise you that we will stay your trustable partner, inshallah. Thank you very much.
Thank you, Firas, for your informative presentation. take the point message and clear differentiation and the complementary with the guidelines, customize the information to our community based on real data in the market rather than studies in US or in Europe. Now we have just a couple of questions. From first question for Dr. Wael from Dr. Iman Al-Shahrawi. She asked, is rash the only sign to differentiate between infectious mononucleosis and follicular tonsillitis?
Thanks for the question. And the answer is infectious mononucleosis, when you suspect it, if you give the reason for getting a rash with the infectious mononucleosis is given amoxicillin clavulanic acid in suspected cases. So it's not part of the disease, it's the virus reaction to the antibiotic. So it's not part of the disease actually. So if you have a case of Epstein-Barr virus or infectious mononucleosis, and as an empirically you give amoxicillin clavulanic acid, you will get rash. So rash, it's the result of the reaction between the virus and the amoxicillin clavulanic acid. It's not a pathognomonic feature to the virus itself, but usually you suspect Epstein-Barr virus. It's very difficult by clinical symptom, but usually with failure to antibiotic, and the patient will come to you with a picture of follicular tonsillitis, taken amoxicillin or any other antibiotic. If he took amoxicillin, he will get rash. If he took any other antibiotic, it will not work. And after that, the condition is getting worse, and the lymph nodes in the neck are getting more tender. And even if you just look about other things that is different from follicular tonsillitis, that is tender lymph nodes, even axillary or enlarged spleen or things like that, you can get ultrasound. But if you suspect Epstein-Barr virus, ask for the IgM antibody. That's conclusive. Clinical picture, it's not that much conclusive for the diagnosis. Even regarding the rash again will come when you give amoxicillin to a suspected case of Epstein-Barr virus. Did I answer your question?
Yeah, thank you, Dr. Wael. Second question to Dr. Wael, who to manage the recurrent tonsil stones without any symptoms of tonsillitis?
Okay, regarding recurrent tonsillar stones or tonsillolith, patients can have several options. They can come to the clinic for removal every now and then. That's the easiest option that you have. Sometimes, if you have available laser devices in your hospital, you can do laser cryptolysis. Laser cryptolysis, you are simply ablating the crypts, so they don't accumulate a lot of tonsillolith. The last option, if this is not working, you can proceed with tonsillectomy. Tonsillectomy is indicated in cases of recurrent tonsillar stones or tonsillolith. So those are the options that worth discussing with the patient, and you can just discuss these options and decide which one that is agreed upon with your patient. And even according to the severity, some patients, they get tonsillar stones every few months. So those patients may be candidates for just removal in the clinic. If they are getting, some females, they are getting tonsillar stones every 1 or 2 weeks, and the bad breath is very annoying to them. So you might think about tonsillectomy or cryptolysis. So according to the patient, after explaining all the options.
Thank you, Dr. Wael. Third question to Dr. Wael from Dr. Rabia Adam. Is there any recommendation to deal with loss of smell and taste after ENT infection?
Okay, so loss of smell and taste. ENT infection can cause loss of smell, not taste. But as we all know, taste and smell, they are working together to enjoy the food. The taste will tell you only if this what you're tasting is sour, salty, or sweet. That's it. But smell will tell you the difference. You have the taste sour, all the salty food will be salty, all the sweet will be sweet. That's it. But you cannot differentiate between, types of fruits and vegetables, for instance. But to have the smell, you can differentiate. So with loss of smell, according to the cause, so viral infection can affect the filaments of the olfactory nerve directly. And we need to ask about this early. So if the treatment begins early, you can get very good results by even topical steroids, and instruct the patient to use the topical steroids in the right way, because many patients don't know how to use the topical steroids. So instruct the patient to use it efficiently in the right direction, and sometimes you can add systemic steroids for 3 to 4 days if the patient has no contraindication to steroids. Sometimes you need multivitamins with zinc, because zinc is usually helpful to the olfactory mucosa. That's regarding medical treatment. And according to the cause, if the virus affecting directly the filaments, this is the treatment. Sometimes the loss of smell is during that because of the nasal obstruction. Sometimes the olfactory filaments are perfectly fine. It's only nasal obstruction that can cause the loss of smell. So once the nasal obstruction is treated, the smell comes back. So, but either if whether the cause is nasal obstruction or direct affection by the virus, the filaments, the early diagnosis means good results in this treatment. But when sometimes you get a patient that says that I have loss of smell 6 months ago or 1 year ago. Well, I don't give him a lot of hopes when he comes very late, because I'm not sure what happened before.
Yeah.
Okay. Thank you.
Dr. Wael. Additional question from Dr. Abdelkafy Fouda. Are steroids have a role in the treatment of otitis media with effusion? Systemic or nasal steroids is better?
Well, steroids have a big role in the treatment of middle ear effusion, and it's usually systemic. Local steroids is effective in treating the nose only, not treating the middle ear effusion. So if you're going to give steroids, just keep them short courses, 5 to 7 days, and it has to be systemic steroids. And we're not looking after this short course of steroids for complete resolution. We are just looking for initial improvement. Once the second tube opens, you can expect full recovery after a few weeks. So just check the patient after this 5 to 7 days of course of systemic steroids, and check the situation. If you can get even initial results, that means you are in the right direction. But yes, it's always systemic steroids.
Thank you. Additional question to Dr. Wael from Dr. Saad Mabrouk. How to differentiate between aphthous stomatopharyngitis from herpetic one?
Okay, so aphthous ulcer, by examination, aphthous ulcer, it's whitish plaque, because this ulcer usually colonized by the oral flora. It's painful. It can be multiple, or it can be just one big. But the herpetic ulcers are usually very painful. They are usually in the palate, around the teeth, in the gums, and the patient will have previous history of both. Clinical criteria, there are both ulcers, but usually the herpetic ulcers starts by vesicles, painful, and they are smaller in size, and they come in clusters. They are just some clusters of vesicles together. But the aphthous stomatitis can be in the palate, in the anterior pillar, pharynx, tongue. So clinically, you can differentiate between the size, the clusters of, if they are clusters inside, clusters together, that's more towards herpetic ulcers.
Thank you, Dr. Wael. Additional question from Dr. May Fauzi. Sometimes antibiotic like amoxiclav do skin rash as a side effect, even without infectious mononucleosis infection. How to differentiate and how to treat infectious mononucleosis after confirming diagnosis?
Okay, so you're talking about the clinical scenario that a patient with a clinical picture of follicular tonsillitis, and you give amoxicillin clavulanic acid as an antibiotic for treatment, and he developed skin rash from the antibiotic itself. And this can really happen. It's one of the complications of the antibiotic, not from the patient having Epstein-Barr virus. But you should ask a question: is the patient getting better from the antibiotic or not? So first of all, you're giving amoxicillin clavulanate acid at the first choice, and that's a good approach. The patient is getting better, but he got skin rash. If the patient is getting better, so that's a bacterial infection, but you need to change the antibiotic because of the skin rash or the complication. But if this patient getting skin rash and he's not getting any better, so I would suggest to test for Epstein-Barr virus to check if this is really bacterial or viral. So skin rash in the beginning, and the skin rash of the Epstein-Barr virus usually in the back, but not always. But as the case goes, you give antibiotic and you see for the initial response. Patients getting good response with skin rash, so that's a bacterial infection. No response with skin rash and the maculopapular rash, just test for Epstein-Barr virus. But clinically, alone to differentiate, that's very difficult. So the response of the antibiotic and testing, if there is no response, testing for the HPV virus would be helpful.
Thank you, Dr. Wael. We have a question to Firas regarding the veneer from Dr. Wael Hamdi. Is the veneer covering Pseudomonas aeruginosa infection?
No, actually no. Similar to all beta-lactam antibiotics like penicillins or cephalosporins, most of them does not cover Pseudomonas aeruginosa. Actually, it is not in most of the cases. Maybe Dr. Wael can help me in this. It is not present in most of cases of community-acquired infections, especially the upper respiratory tract, except some cases from pool swimming or something like this in otitis media in certain adults. Am I right, Dr. Wael?
Well, I wouldn't prescribe it for suspected Pseudomonas unless if I can get culture and sensitivity results that confirm this.
Thank you, doctor.
Thank you.
So I think clear. Yes,
additional question from Dr. Ali. Is the veneer can be used in pregnancy and lactation?
It is category B. Category B is similar, yes, to paracetamol and amoxicillin and other cephalosporins. Category B.
Additional question for Dr. Wael from Dr. Tariq Idris. Shall I discontinue the nasal CCS directly after initial improvement?
The nasal, excuse me, I didn't get the question.
The nasal CCS.
Corticosteroids.
Yeah.
After what?
After initial improvement?
No. Well, we're giving nasal steroids. At least you should give it for 10 to 15 days. Yeah. So, I mean, after initial improvement, you mean 3-4 days? That's not enough for nasal steroids. Yeah. So, at least you should take it for 10 to 15 days if you're going to prescribe that. And just to add something about Dr. Firas' question regarding pregnancy, actually, it's one of the safest medications during pregnancy. Of course, according to the guidelines, we should prescribe it from the second trimester. But even in severe cases, we can get some bacterial infection the first trimester. After approval of the OB/GYN doctors, we can sometimes, with their approval, with explanation of the risks to the patient, we can even use earlier. So it's very safe medication during pregnancy, yes.
Additional question from Dr. Raed Adam to Dr. Wael. In which case can I treat otitis media using airdrops or systemic antibiotic?
Okay, if you're giving eardrops, when we're talking about otitis media, that's inflammation in the middle ear. That's the problem behind the eardrum. So the rule for eardrops in otitis media, in middle ear infection, it's not that much. You're not adding a lot. Maybe it's just soothing agent, but as a treatment modality, that maybe you can use it in otitis externa, but otitis media, I don't think it has a big role in the treatment. And are we talking about eardrops soothing agents, or we're talking about antibiotics with steroids eardrops? If you're giving antibiotic, well, I don't think it will cause any harm, but it's not the mainstay of treatment because your drops will not reach the site of infection. Okay, so mainly systemic antibiotics. But once you encounter a case of otitis media with perforation, because that can happen if the patient came to you in, in the late stage. I mean, stage 4 is the stage of perforation. So if the patient came to you with perforation, you can give systemic and topical. But just otitis media, I think systemic antibiotics is more than enough.
Yeah. Question to Dr. Wael, what about central criteria in diagnosis of tonsillitis?
What criteria?
What's about central criteria?
Central criteria?
Yeah.
I don't get the question.
Maybe
I don't think I got it right.
Central criteria in diagnosis of tonsillitis from Dr. Emmanuel. Maybe we can drop this question. I have my own question about your preference regarding the veneer. You prefer to prescribe it once, 600 milligram once, or 300 twice daily? What's regarding your practice in this point?
That's in my practice, in my experience, I found better results when we give the 2 capsules once daily.
Yeah.
I don't have controlled trials to support this scientifically, but that's just my own opinion. I find it much better, and I find better results when you get, not just regarding compliance. I'm not talking about compliance here. I'm talking about the effectiveness in treatment, what we were treating of upper respiratory infection. 2 capsules together, I find it more effective even in giving twice daily.
Thank you, Dr. Wael. Last question from Dr. Samer about the availability of the veneer in Saudi market. It is now, I can answer this question by myself. The veneer now is available as a suspension and the capsule. Both are available in the market. And by the way, this is the last question. Thank you, Dr. Wael, for your informative and presentation touches the clinical and add value for the clinical practice of healthcare professionals. Thank you, Dr. Firas, for your informative presentation and to the point, clear point of competitive advantage of the veneer. I have to thank you all for participation in our seminar. We are looking forward to meeting you face-to-face soon after this pandemic end, and participate in our upcoming continuous medical education webinar later on. Thank you for all attendees, and thank you for Dr. Wael and Dr.
Thank you so much for having me, and thanks for the attendance. Thank you so much. Thanks.
Thank you all. Ramadan Mubarak, inshallah.
Thank you.
Assalamu alaikum.
Alaikum assalam.